Thank you, everyone, for coming through to our Fireside Chat number 196 today. And today we'll be having Dr. Shoyab Wadee, who is going to take us through an introduction of onconephrology. But before I hand over the mic to him, I would like to just briefly introduce Dr. Wadee. Dr. Wadee is a specialist physician and a nephrologist in private practice in an academic private hospital in Johannesburg, South Africa. He is also the former president of the South African Nephrology Society and serving as a current executive committee member. His primary focus is on improving access to care, kidney diseases. Prof, I believe this is a very brief and short introduction. Please, you're more than welcome to give us your talk. Thank you so much and welcome.
Thank you, Mazar, and thank you for the invitation. I think I need to share my presentation and then we can get going. I'm not going to linger too much on each slide because I think the idea was to do a bird's eye view of onconephrology. So onconephrology obviously is a recent subspecialty of nephrology which is gaining traction, not so much in the African continent, but certainly in Europe and North America, where the numbers of nephrologists allow nephrologists to subspecialize within the branch of nephrology. One of the most significant branches, which has sort of emerged, is onconephrology. Doesn't mean that the knowledge which is embodied in the specialization is not important for us. And one of the things that happens is, as a subspecialty develops, the information around dealing with that subspecialty increases and explodes. So in the literature, there's been lots of publications now looking at onconephrology, and I'm going to lean heavily on a recent series published, and I'll show you some of the summaries of those publications, just so that we can have a taste of onconephrology. And I certainly think it's important for people to understand the different aspects which are involved. So onconephrology, obviously, it's self-explanatory. So it's a subspecialty at the intersection of oncology and nephrology, and it focuses on how kidneys are affected in patients with cancer and how the kidney disease affects the cancer, in particular the treatment of the cancer. So it's important because we know there's a significant increase in the incidence and the prevalence of chronic kidney disease, and at the same time, there's an increasing risk of an increasing diagnosis of patients with various types of cancer. And it's quite common that patients with cancer will have some pre-existing chronic kidney disease or will develop kidney disease during the course of the cancer. And on the other hand, we know that patients with chronic kidney disease, especially patients with end-stage renal failure, at increased risk of developing malignancies, and certainly in the transplant space, post-transplantation, the risk of malignancies increase. So as these diseases coexist more and more together, our need to develop specialist decision-making processes around how we manage the diseases has increased, hence the development of this subspecialty. So I mean, there are multiple mechanisms of injury of the kidney. I'm going to go through some of them, but overall, we know that whether you're talking about acute kidney injury, chronic kidney injury, you can define it anatomically, so you can define it whether it's pre-renal, intrarenal, and within the kidney, various parts of the kidney, the glomerulus, the tubules, the interstitium, and vessels getting into the kidney, and then the post-renally, obviously, the obstructive elements, whether it's from the pelvis down to the ureters, into the bladder, and all the way down to the urethra. Similarly, some of the pathogenetic mechanisms relate to chemicals which are produced by the cancer or substances which are produced by the cancer, metabolic derangements related to the cancer, complications of the cancer, for example, vomiting in patients who have gastric outlet obstruction, all the way down to treatment-related complications where the treatments which are given to the patient for the cancer are either toxic to the kidney or are affected by the kidney function. One of the first things we need to consider is that the evaluation of kidney function in patients with cancer may not be the same as the evaluation in other groups of patients. So we know that patients with advanced cancer are particularly sarcopenic and may have significant wasting, and that obviously makes creatinine evaluation a problem. Urea may be falsely low in even in pre-renal patients, because patients have significant derangements in protein intake, especially if the appetite has been affected substantially. And then creatinine can also be affected to some degree by protein intake. We know that there are drugs which interfere with creatinine secretion. Obviously, some of them are not particularly related to cancer treatment, like trimethoprim, but there's significant amount of drugs that we use to treat cancer, chemotherapeutic agents or agents which we use in the treatment of cancer, which can interfere with creatinine secretion and push creatinine up falsely, even in the context of a normal kidney function. And then this is not made that much easier by cystatin C, although obviously it is a separate entity to check for the degree of kidney failure or kidney function. So cystatin C can be produced by some cancers, which may falsely raise the cystatin C level. And we know that the use of steroids in many cancers, especially hematological, but also other cancers, and also for control of bone pain and so forth, may increase cystatin C levels. So cystatin C can also be somewhat unreliable. Look, in some instances, it's not exactly necessary to know the exact degree of kidney dysfunction or the exact kidney function. If there is kidney dysfunction, which is obvious, but in some instances, it's important to know the exact degree of kidney function. So, for example, the dose of cisplatin or some other chemotherapeutic agents may need to be reduced in patients with a GFR even under the 60 moles per minute range. And when you look at that range, it's possible that some of these interfering factors may affect your assessment of GFR. And if it's really important, it may be necessary to do some type of measurement of GFR rather than a calculation of GFR using clearance, nuclear clearance, or iothalamate, iohexol, some type of clearance mechanism which is independent of creatinine cystatin C, and that can give you a more accurate picture. This is just a broad picture of some of the types of mechanisms of kidney injury and manifestations of kidney injury in patients with chronic kidney disease, from the need for nephrectomy in patients where the kidney is affected, for example, renal cell carcinoma or tumors which affect the kidney, to AKI related to, as I mentioned, pre-renal, intrarenal, and post-renal factors, to the nephrotoxicity of cancer drugs. And for some reason, I've got paraneoplastic renal manifestations here twice. It must mean it's very important, or maybe I just didn't notice it was there twice. Okay, so this is the series I was alluding to earlier. It's in ACKD, which is the Advances in Chronic Kidney Disease. It's published between 2021 and 2022. There are actually some more recent reviews and summaries, but I like this one. There's 2 editions. The entire edition is dedicated to onconephrology, so in 2 parts, part 1 and part 2. And each little review is accompanied by a little summary slide like this, a visual abstract, just to summarize some of the things which are done in the review. So I've relied heavily on these visual abstracts because I think it serves the purpose of this talk by giving us a sort of bird's eye view of some of the things which can occur. So we know that AKI can occur in patients with cancer, sometimes directly related to the cancer. For example, thrombotic microangiopathies related to certain malignancies, obstructive nephropathy, which is common with cancer of the bladder, prostate, CA cervix, and then right down to acute light chain nephropathy, where there's acute release of light chains, and tumor lysis syndrome related to release of uric acid into the circulation. So these usually typically occur over days to weeks, drop in the urine output and clearance, and obviously can vary from mild to severe and may need to be treated with anything from fluids to dialysis, depending on the severity and the cause of the acute kidney injury. Okay, treatment is important, and several types of chemotherapeutic agents, including conventional chemotherapy, cisplatin obviously being the common one, which is nephrotoxic, But remember, chemotherapy can cause tumor lysis syndrome and release of other substances from tumors. But some of the immunotherapy agents can cause acute interstitial nephritis, cytokine release syndrome, and we'll go through some of that. Okay, so that's acute kidney injury. The next focus was on tumor lysis syndrome. So tumor lysis syndrome, just remember the kidney is not the only organ which can be sort of affected or which can manifest during tumor lysis syndrome. There's massive release of substances from tumors, and the massive release of uric acid deposits in the tubules and causes an acute kidney injury. And then this is worsens the accompanying hyperkalemia. So potassium is massively released from the dying tumor cells as well. And as the kidney function worsens, that potassium is not able to be excreted. Even in the context of normal kidney function, the potassium may rise, and in that instance can cause cardiac disturbances, and even the release of high amounts of phosphate can significantly drop your calcium and cause neurological and cardiac disturbances, including seizures. So I know with tumor lysis syndrome, we focus from our side on the kidneys, but the manifestations are not necessarily limited to the kidneys. We know that the prevention of tumor lysis syndrome involves a prehydration, alkalinization of the urine, and then obviously adjusting chemotherapy for the burden of the disease, and then watching for tumor lysis syndrome. There may be the need for dialysis in patients who develop that. If you have RAS uricase available, it can obviously cause lysis of the uric acid. And then allopurinol may reduce the conversion of purines into uric acid. So patients can be preloaded with allopurinol as well. So, I mean, I don't think this is a mystery to nephrologists and the people on the call. It's just a matter of looking out for it and recognizing it. Then let's look at the glomerular disease. Now, I wanted to concentrate on the glomerular diseases which are related to the malignancy rather than related to chemotherapy. We'll get to some of the glomerular diseases related to chemotherapy later on. But we know myeloma, for example, can cause a variety of glomerular abnormalities ranging from light chain deposition to amyloidosis inside the kidney. Obviously, amyloidosis can also occur with lymphoma, especially if it releases light chains. You can also get minimal change disease, or FSH, as a manifestation of lymphoma, and we are all well aware of the association with membranous glomerular nephropathy and various cancers. There's a sort of consensus around which patients should be investigated for malignancy, because remember, some of these conditions like minimal change disease, membranous glomerulopathy will occur outside the context of cancer and may precede the diagnosis of cancer. So especially for membranous, we usually will investigate, especially in older patients, for an underlying malignancy, an occult malignancy, particularly in the lung and GI. Look at the abdominal sonar and scope these patients, look at the prostate and so forth. But it may be necessary in some older patients, even with ANCA vasculitis or new onset IgA nephropathy, to look for a malignancy. And then thrombotic microangiopathies can occur in the context of cancer. So it's one of the manifestations of malignancy is a thrombotic microangiopathy inside the kidney. So if you have an occult thrombotic microangiopathy in an older patient, particularly, you may want to look at cancer. In younger patients, atypical HUS and so forth may be much more likely to be a manifestation there. But in an older patient, you may want to consider malignancy as part of your differential and investigate the patient for that. Okay, obviously amongst many other causes. Many patients require surgery for their malignancies, and these surgeries can have multiple complications. The patients obviously don't always go into these surgeries very well. They may be wasted, they may be malnourished. They're often older because cancer tends to occur in older individuals. They may have other chronic conditions. And then during the procedure, various things can happen like bleeding. And then post-op, many patients may receive analgesia and so forth. So, which is obviously can become nephrotoxic. So you can see the common ones obviously are ones which deal with the kidneys or happen around the kidneys, but or are higher risk surgeries, particularly like thoracic surgeries. And often we will only be consulted when the patient develops AKI post-op. But certainly these patients have pre-existing chronic kidney disease. It may be necessary to be quite wary of them as they go through these operations. Other abnormalities which occur in the context of cancer are abnormalities of sodium and potassium dysregulation. I think the one which people are well aware of, obviously, is SIADH related to malignancies in the chest, in the brain. But certainly a variety of other abnormalities can occur, especially if patients are dehydrated. So sort of hyponatremia or hyponatremia in the context of dehydration may occur with patients who are vomiting or have GI losses, patients with villus adenomas and so forth and so on. And then patients who are treated with certain medications may occur, may also develop hyponatremia, and some chemotherapeutic agents can cause SIADH. Important to remember multiple myeloma, which causes pseudo hyponatremia in the context of a very high paraprotein load. In terms of hypernatremia, obviously patients have tumors in their brain and develop central diabetes insipidus that can cause severe hyponatremia. But again, severe dehydration, loss of fluids, the use of hypertonic saline or mannitol for certain types of malignancies and brain tumors may potentiate hyponatremia. So, and then some drugs can cause diabetes insipidus and then cause wasting of free water and lead to nephrogenic diabetes insipidus, particularly the platinum compounds. In fact, there's various drugs which can cause tubular toxicity and are associated with hypernatremia. So in the context of a patient with cancer who develops hypernatremia, obviously you need to go through or hyponatremia, you need to go through the motions of assessing fluid status, looking at the urine, are they concentrating the urine, could they have diabetes insipidus, or do they have SIADH if they're hyponatremic, and go through the process of making a diagnosis and then getting through to the appropriate treatment, and then making sure we review the drugs in detail to make sure if the drugs could be contributing. Hyperkalemia can occur, as you mentioned, with tumor lysis syndrome, but can also be iatrogenic if patients are getting potassium replacement. Can occur besides with tumor lysis syndrome, but also with hemolysis, in patients with severe hematological malignancies, with, for example, CLL, with leukocytosis and breakdown of leukocytes. They may develop hyperkalemia. And then patients may develop Addison's or adrenal insufficiency in tumors which metastasize to the adrenal, which is not all that rare. And then hypokalemia, obviously, the common causes are GI losses, vomiting, diarrhea. There are some drugs which can cause potassium wasting and a Fanconi-like syndrome, so you need to be aware of that as well. I think most of you will know that magnesium abnormalities can be associated with cancer, especially hypomagnesemia. Some drugs can cause them. Some cancers can produce substances which cause hypomagnesemia. And then hypophosphatemia can also be caused by loss of fluids, GI fluids, vomiting, poor appetite. But also some tumors can produce FGF23-like substances, which can lead to phosphate wasting. And then remember, some tumors can produce PTH-related peptide, or actually rarely PTH, which can push the calcium up and the phosphate down. I'm not going to linger too much on hypercalcemia. I think hypercalcemia, most of you know the different mechanisms, whether it's direct osteolysis production of PTH-related peptide, or some rarely excess conversion or production of vitamin D. And then hypocalcemia is predominantly related to very high phosphates, post-tumor lysis syndrome, and then some medications which may be used, for example, bisphosphonates used for myeloma may cause hypocalcemia if the patients are overtreated, or if actually I find that it's common that most myeloma patients on repeated doses of bisphosphonates will develop a bit of hypocalcemia. Another thing which comes up commonly for us as nephrologists, and I think most nephrologists are well aware of it because of our experience with end-stage renal failure and patients with malignancies and end-stage renal failure, is the risk of anemia and the treatment of anemia, and some of the controversies around anemia, particularly the use of ESAs and the increased risk of malignancy linked to or growth of malignancy linked to the use of ESAs. You need to individualize in these individual patients, look at the risk benefit. If there's a chance of cure, you may want to significantly reduce the exposure to ESAs in those patients. If you're looking at palliative care or control of the disease and you want to reduce blood transfusions, you may continue to use ESAs to reduce the need for blood transfusions and improve patient well-being. There's no good data around the use of HIF-PH inhibitors at the moment. But certainly the simple things you can do is minimize loss of blood, optimize the nutritional deficiencies like iron, B12, and folate, reduce the chronic inflammation that you can to try and optimize the HP without the use of ESAs before you even get there. Okay. Just a few words about transplantation. We know that there's increased risk of malignancy, particularly malignancies which are driven by viral oncogenic mechanisms like EBV or HPV. And obviously the burden of immune suppression may reduce the risk of those malignancies. But still, cancer occurs much more frequently in patients post-transplant. So screening is important. Age-appropriate screening, screening for skin cancers, pap smears. So those regular screenings, I think, should be adhered to and looked at carefully. And then obviously you may want to change immune suppression in patients who develop malignancies. If they're going to get chemotherapy, which is also going to affect their immune system, or it's going to cause bone marrow suppression, you may need to reduce the total burden of immune suppression related to transplantation. You may need to change to a mTOR inhibitor, for example, in patients with skin cancers, if that's not contraindicated. And then going back to pre-transplant, obviously some patients who have a cured cancer may be able to be transplanted, and there are guidelines on the various waiting times which are necessary for different cancers, ranging from no waiting time from patients with low-grade prostatic malignancies or skin malignancies to patients who are never transplantable with melanoma, for example, or with myeloma potentially. Okay. The question of renal biopsy in cancer patients arises. I'm not going to say much here. The indications and the risk-benefit calculations are going to be the same. You're going to see, is this biopsy going to change the management of this patient? Are we going to find something which may change the way we manage this patient? Is the chemotherapy potentially causing this this problem in this patient? You would have to see what the risk of bleeding is, what the patient's size of his kidneys are, how rapidly the kidney function is worsening, and make a decision. It's not particularly contraindicated to do a kidney biopsy in patients with cancer, and it may often be very useful to do a biopsy, especially where the diagnosis is not clear and you're not sure whether, for example, the chemotherapy is causing interstitial nephritis or something like that in the kidney. It may be a good idea to do the biopsy. Okay. So I'm just going to go through some of the treatment-related principles. We know that the major treatments for cancer include surgery, radiation in various forms, and chemotherapy. And when you look at chemotherapy, if you look at the literature and onconephrology literature, certainly chemotherapy is divided into conventional chemotherapy, and this is chemotherapy that we've used in a sort of non-directed ways, which affects rapidly dividing cells, and you are all aware of the different classes of chemotherapy that we've used for decades, from alkylating agents to platinum compounds and various other agents. And then you're looking at immunotherapy. So immunotherapy is sort of the new, more recent kid in the block, which potentiates your immune response to cancer or directs your immune response to a cancer. And there are various sort of different branches of immunotherapy, from checkpoint inhibitors to BiTE therapy to CAR T cells, and they have some overlapping toxicities, but and obviously some different toxicities depending on the therapy. And then the newer targeted therapies using small molecular agents or antibodies, which target small molecular targets, particularly tyrosine kinases or other kinases in the kidney, which obviously have become very popular in the last 10 years or so. And they have their own sort of list of toxicities which they may cause in the kidneys. These are just an overall sort of picture. I showed it to you a similar picture overall earlier, from AKI to progressive CKD to just isolated electrolyte disturbances and tubular dysfunction to just causing hypertension. For example, VEGF inhibitors may cause significant hypertension by their effect on the endothelial health. Interstitial nephritis related to either dose-related or idiosyncratic reactions to the kidney stones in some instances, and then various glomerular diseases which can cause nephrotic syndrome and other manifestations. There are some chemotherapeutic agents which can cause cysts. I mentioned SIADH as part of the spectrum of tubular disorders, and thrombotic microangiopathy. Obviously, the typical cause there is mitomycin. So that's just a different way of showing the different areas where the kidney is affected. I mentioned earlier that there are drugs which affect tubular secretion, and there are lists of these drugs. So if you're not sure, and I mean, most of us will not be sure. We're not dealing with these drugs every day like oncologists. So it's easy to look it up. If you call to see a patient and the patient's creatinine has risen and you're not sure whether it's an actual injury to the kidney or the patient has got a drug which is affecting the kidney, you can look up the list of drugs and then obviously make a decision. If the patient's blood pressure is normal, the urine is bland, the rise is stable and is not changing after introducing the drug, it's more likely to be, and it can be attributed to a drug which is known to cause a decrease in creatinine secretion, then you can probably attribute it to that drug. And obviously, a good rule would be then if you can stop it, if it's safe to stop it, and the kidney and the creatinine, I wouldn't say kidney function is probably already normal, and the creatinine comes back down, then that's sort of proof of the pudding that that's probably the cause of it. But it's something to keep in the back of your mind. Obviously, I'm sure most of us are aware now of the use of dolutegravir and trimethoprim and those other drugs, which we now sort of become quite comfortable with, expecting a rise in the creatinine with those drugs. So once you've ascertained that it's not a rise in the creatinine, you now want to work out, before the patient even gets a therapy, can this therapy cause kidney injury? How do you prevent that? How do you treat that if it causes a kidney injury? And then the last question for a nephrologist is, if the patient has an existing chronic kidney disease, how does it affect the type of chemotherapy that the patient gets? So I'm not going to answer those in order. Let's go to the last one first. Does the patient's kidney dysfunction impact on his chemotherapy? So that's a question we get all the time as nephrologists. This is not a new question for us. Our patient has chronic kidney disease. Some of them are on dialysis, and the patient needs to get chemotherapy for some type of cancer. The oncologists are also well aware of the dose reductions which are required. And then sometimes you need to change the regimen completely. For example, if there are alternative regimens in a patient who is got advanced stage chronic kidney disease, CKD4, or so, where the use of chemotherapy may push the patient over the edge and push them into a situation where they require renal replacement therapy, you may use an alternative therapy which will not do that. Similarly, if a patient has very mild chronic kidney disease, you may need to watch them closely and then discontinue the chemotherapeutic agent or use something else, or decrease the dose depending on the type of toxicity that they get. Obviously, it's difficult for us to extrapolate because many of the studies in these drugs were not done in patients with chronic kidneys, like most drugs, and the dose reductions and adjustments are based on pharmacokinetic sort of calculations based on the percentage of the drug which is excreted. So this is an area where therapeutic drug monitoring may be important in these drugs to make sure that an effective dose of the drug is being delivered while not overdosing the patient. So I think we may find that in the future, more and more therapeutic drug monitoring trials in even chemotherapeutic agents, as there are in antibiotics now, will start emerging, because many of the previous ways of us dosing drugs were just based on pharmacokinetic extrapolations. And we do know that as your kidney function decreases, sometimes your extrarenal clearance of some drugs increases. We also know, for example, in patients on dialysis, that some of the other drugs that we use may interfere with the use of chemotherapeutic agents. So, for example, if you're using a chemotherapeutic agent which is markedly marrow-suppressant and you're expecting thrombocytopenia, you may have to discontinue any aspirin that you're using for the patient's vascular access. You may have to stop heparin on dialysis. So I think it's important to know what co-toxicities may occur with the drugs. I'll also be aware that in oral drugs that you take, phosphate binders that we use to bind phosphate may often interfere with absorption of those drugs. So I think more and more we're going to have to start relying on therapeutic drug monitoring as time goes on. The next question is, can the therapy cause kidney injury? So I'll go through some of that. Almost all the drugs can cause kidney injury by some mechanism or other, either directly through a recognized dose-related mechanism or via an idiosyncratic mechanism where the understanding of how they do it is not well known. And obviously some drugs cause kidney injury indirectly, for example, by causing tumor lysis syndrome. Or indirectly by causing GI side effects and severe vomiting and diarrhea. And I'm sure every single person on this call has admitted a patient with acute kidney injury post-chemotherapy after severe vomiting or diarrhea, or one of those side effects. And obviously, if they develop neutropenic sepsis and other complications, they're at risk of acute kidney injury. We know the risk factors for toxicity even before you give the agent. Patients with existing chronic kidney disease, with volume insufficiency. It doesn't have to be absolute volume depletion. It can be relative volume depletion, like patients with chronic heart failure or with liver disease who have a relatively depleted intravascular or effective intravascular volume. There may be concomitant medications used which are nephrotoxic for pain, or in the context of myeloma and other hypercalcemic malignancies, bisphosphonates. Patients may already have a known sensitivity to a particular drug, in which case a history is important to know whether the patient has had an allergy or a reaction to a particular drug. So these are some of the common examples. I'm just going to run through them. I mentioned platinum. Cisplatin is the most well-recognized one, with complications related to ATN, thrombotic microangiopathies, hypomagnesemia with tubular magnesium wasting, and a Fanconi's-like syndrome with wasting of multiple proximal tubular sort of substances. Hydration can prevent some of the toxicity of cisplatin. Obviously, it's usually reversible, but it can cause CKD in some patients, especially if the use persists. Oxaliplatin is probably the least toxic of the platinum compounds. Okay, cyclophosphamide, most of us are aware of its urological complications, particularly hemorrhagic cystitis and malignancy, but it can also cause an SIADH when used in high doses, especially the doses used for certain malignancies. So you may want to be aware of that. And then the prehydration that many people use to prevent the urological side effects can potentiate the hyponatremia that you will get with the SIADH. So just bear that in mind. Ifosfamide is a more toxic alkylating agent than cyclophosphamide. I've never seen it used in our setting. It's used mostly in kids. Can cause Fanconi's and other tubulopathies. So ifosfamide is a more nephrotoxic alkylating agent. And then some of the nitrous ureas can cause a chronic interstitial nephritis via a mechanism of alkylation of tubular cell proteins, and they may also cause tubulopathy. Methotrexate in the traditional doses they're used by rheumatologists is rarely nephrotoxic, although it can accumulate in patients with chronic kidney disease, but in high doses can precipitate in the tubules and can cause acute kidney injury. It's worse if the patient is dehydrated. So we try and make sure the patient is well hydrated, and you can alkalinize the urine. Can also cause an SIADH, but usually that's reversible. Premaxted, which is a sort of pre-drug for methotrexate, can cause idiosyncratic nephrotoxicity. Gemcitabine, there's reports of thrombotic microangiopathy, and SIADH is described with the vinca alkaloids. Anthracyclines have been associated rarely with glomerular lesions, and these can cause nephrotic syndrome. And as I mentioned earlier, mitomycin was the typically taught chemotherapeutic agent, which can cause a thrombotic microangiopathy. Myeloma is a drug we deal with commonly in patients with chronic kidney disease. I just thought I'd make a special note of the drugs that we use. Thalidomide is not nephrotoxic and not renally excreted. It's relatively safe in terms of effectivity. Obviously, it will vary. Lenalidomide, which is used a lot now, is mostly excreted renally. So I think, we've had lots of patients overdose with this by our oncologists. You need to just keep a close eye on that. you may find that some of your patients come back from the oncologist with a full dose of lenalidomide, and then they develop severe toxicity, neuropathic side effects, and so forth and so on. So you may want to make sure that dose is adjusted properly. There have been also reports of acute interstitial nephritis, Fanconi's tubular dysfunction, and in patients with transplants, graft rejection. Okay, pomalidomide, we don't have much data on whether it has any toxicity. It's not used much in South Africa. I've never seen it. Melphalan has been associated with SIDH. The common drugs used now in terms of the proteasome inhibitors, most of them can cause idiosyncratic rare sort of reactions, including acute interstitial nephritis and TMA. You will probably have to biopsy a patient to make this diagnosis, which obviously can be a bit risky in a patient with a TMA, especially if they're severely thrombocytopenic. But remember, if it's a renal limited TMA, often the patient won't be severely thrombocytopenic, and you can safely do a biopsy. Okay, these are just some of the molecular targets and the development over the past 20 years. They work in various ways by blocking sort of second messenger systems which potentiate cell growth and cell transcription, tyrosine kinase, serine threonine kinase inhibitors, and they inhibit various systems. I'm not going to go through them. There's various classifications of how they work, but just some broad examples. I think the one which we all should know about are the angiogenesis inhibitors. So these are drugs which block the VEGF system. The common ones that you're aware of are Avastin, which is obviously used in the eye, but is also used as a systemic chemotherapeutic agent. And almost all these drugs, as a class effect, can cause hypertension, worsening hypertension, and can cause the nephrotic syndrome. Usually, they seem to be toxic to the podocyte. You do get the podocyte abnormalities, and it seems that the podocyte health is developed on adequate VEGF. So inhibiting these vascular endothelial growth factors may lead to unhealthy podocytes, and possibly is the mechanism for these patients developing nephrotic syndrome and hypertension. On biopsy, some patients have also been manifested as with a thrombotic microangiopathy, and it's possible that VEGF inhibitors, I think it's almost certain that they would affect endothelial health as well. So the recommendation currently is if patients are severely proteinuria, that you stop it. And we've had a couple of cases, you stop it and the patient usually resolves. If not, you would obviously treat them as other forms of proteinuric nephropathy to try and reduce the proteinuria. There's no clear evidence that using steroids or other immunosuppressive drugs makes a difference there. There are other drugs which block VEGF as well as tyrosine kinase, which may also cause proteinuria and thrombotic microangiopathy. So I think that's the one for us to be aware of. There are various other small molecule chemotherapeutic agents which have a variety of manifestations. I think if you're not sure, almost all of them really can cause some type of renal dysfunction or some type of tubular dysfunction. So I think if you're not sure, you would look at it. The FGF receptor inhibitors, as you would expect, would act like FGF23. Well, they would block the effect of FGF23 and they can cause hyperphosphatemia. So that's sort of drugs which act in the opposite way to FGF23, which is a phosphoturic agent, and they seem to block the phosphoturic effect of FGF23. And these patients manifest with hyperphosphatemia, and you would treat them like how you treat patients with CKD and hyperphosphatemia with dietary adjustment and phosphate binders. Okay, we know that the mTOR inhibitors can cause proteinuria and podocytopathies. Just to go through some of the other types of targeted therapy. So this is sort of falls in between all the different types of therapy, between immune therapy and between small molecules and between radiation. So this is peptide receptor radioligand therapy. So basically, if you look at the pictures here, what you're doing is you use a radioactive molecule linked to a ligand, and that ligand is a ligand for a receptor on the cancer cell. So you would have to find the receptor which is specific for the cancer cell, make sure that that peptide binds to that ligand. So obviously, if the cancer cell is secreting or is a target for a certain hormone or substance, then it becomes easy to find that ligand. So it's often used in neuroendocrine tumors. And it's delivering the radiation dose right up to the cell at a cellular level. So it works very well. The problem is most of these radioactive ligands are then excreted to the kidney, and they give the kidney a significant dose of radiation and can cause multiple forms of kidney injury. And we've seen patients with acute kidney injury as well as some chronic kidney injury in patients who've received PRRT therapy. There are some the mechanisms which people use, like prehydration, to prevent the toxicity. And then if you absorb it with if you infuse it with an amino acid solution, the amino acid solution sort of competitively inhibits the tubular absorption of the radiotracer. Remember, there's large molecule absorbed through large protein transporters in the proximal tubule. So if you saturate those large protein transporters in the proximal tubule with amino acids, you may get less toxicity. Okay, going to the immune therapies, I'm going to go through some of them. So bite therapy is a similar type of concept where you direct a immune cell, now not radiation, but you direct an immune cell to the cancer cell by using a sort of marker which has got a ligand both for the immune cell as well as the cancer cell. So it basically brings the immunological cell in contact with the cancer cell and then allows the immunological cell to attack that cancer cell and immunologically destroy the cancer cell. CAR T cell therapy is a therapy where T cells are removed from the patient. They are trained to or sensitized to antigen on the cancer, and then they're amplified and then reinfused into the patients and will have a directed immune response at the cancer. So, and then the other form of immune therapy is immune checkpoint inhibitors, which block the normal immune checkpoints, which slow down your immune response. So they may block CTLA4 or NDPT or PD-L1, and these will sort of prevent the immune system from being inhibited and will allow them to be more effective against tumor cells. Now, obviously, the risk is that you have immune overstimulation, and one of the side effects is sort of an interstitial nephritis related to sort of immunological injury to the kidney. Also, these patients can get a cytokine release syndrome with massive immunological injury related to release of cytokines. So those are sort of the main side effects related to immunotherapies. This is just in another form, the types of therapies. So this is a nice slide from the same group of papers, just summarizing those features. Another thing which has been described, particularly with the immune checkpoint inhibitors, is again nephrotic syndrome. So in some of these patients, you may want to biopsy those patients to see if they've developed some type of glomerular lesion, which may require. So it can be difficult if your patient has comorbidities, is diabetic, has got a bit of proteinuria. You're not sure if it's the CTLA4 inhibitor or the immune checkpoint inhibitor, or whether the patient has progressive diabetic nephropathy, that type of thing. You may actually need to biopsy the patient to see what the pattern of injury in the kidney is and whether it's more likely to be drug related or whether it's a typical diabetic nephropathy. So that's sort of one of the examples where a biopsy may be useful. In terms of CAR T cell therapy, we're mostly looking at cytokine release syndrome, which can cause a variety of manifestations. I think that slide is missing. Oh, here we go. So cytokine release syndrome can cause a variety of manifestations, not limited to the kidney, but obviously acute kidney injury can be one of the manifestations of massive cytokine release. I mean, this is almost akin to the massive cytokine release you would see in sort of septic shock, with hypotension, tachycardia, organ dysfunction, acute respiratory distress syndrome, acute kidney injury. So confusion, so those are coagulopathy. So these are the type of things that you would get in that syndrome. Okay, and it can be problematic because these patients have cancer. They may well have septic shock. So you would have to obviously differentiate cytokine release syndrome from septic shock in the right context. This is a guidelines which have been put out. I think this is the American Society of Oncology, looking at your approach to immune checkpoint inhibitors, and they define it as definite damage, possible damage, or probable damage and possible damage based on different criteria. Obviously, definite damage is if you've got a biopsy. Probable is if you've got a significant rise in creatinine and then no other obvious factors, and then a relatively obvious etiology. And then possible etiology is where you've got some rise, but there are many other possible factors. So based on that, you would have to make a decision how to treat them. And then the severity would also give you some guidance into how to manage these patients. Patients with mild disease, you may just stop the drug or reduce the dose or give them more fluid. In patients with moderate to severe, you may need to consider corticosteroids where you think there's a significant immunological activity in the kidney, like an acute interstitial nephritis, or if they have a full-blown cytokine release syndrome, obviously you're going to have to give them immune suppressants. And then in patients with very severe chronic kidney disease, you may have to permanently discontinue the drug. Or very severe kidney injury, you may have to permanently discontinue the drug, and you may actually need to use long-term treatment for some of these patients if they have ongoing inflammation, which persists beyond a few weeks. So there are some guidelines which are available. I'm not going to linger on them. As I said, this is more of a bird's eye view. I didn't want to go into detail. So just to summarize these last few slides, I'm almost at the end, Probima, so you can make your meeting, hopefully. Maybe we'll have time for one or two questions. Preventing toxicity is important. We mentioned most of these things: hydration, avoiding nephrotoxicities, optimizing comorbid conditions, and where necessary, urinary alkalinization. And there are specific things which may reduce toxicity of certain drugs. And some of these guidelines are available in various reviews. Okay, these are the two articles the two issues I was talking about on the in the ACKD journal, which is obviously it's a review type journal, which is published by the National Kidney Foundation in the US, and it's from 2021 and 2022, and I would recommend that people have a look at this. There's also a review recently in the core curriculum for Onconephrology from AJKD, and there's a couple of there's actually plenty of reviews now in the past few years. In terms of management, may go from discontinuation of a particular drug right up to changing the regimen to something else completely. Okay, and that will depend on the severity of the disease, what alternatives are available, and then you have to individualize. If the patient's prognosis is very poor from the malignancy, you may rather discontinue the chemotherapy so they don't spend the last few months of their life on dialysis. So I think some wisdom is sometimes required there. Okay, so there are multiple opportunities for renal injury, both from the cancer itself, as well as the treatment of the cancer, as well as comorbidities or complications related to surgery. So it's important for us to be aware of this. I think this is going to be an emerging topic. Most nephrologists are going to deal with. In fact, all of us will deal with patients with kidney disease as well as cancer, and all of us will want to mitigate any risk to the kidneys from the cancer, and obviously optimize the treatment of the cancer in the context of patients with existing kidney disease. So I think it's important for us to sort of improve our knowledge in this area and continue reading. I hope I've given you just a bit of a taste of onconephrology. There is an American Society of Onconephrology, which I think you can become a member of and has some benefits, and obviously has regular CPD presentations. So I think for those who are more interested, that's an area which they can explore. Thank you.
Thank you so much, Dr. Wadee, for this comprehensive summary on onconephrology, and clearly everybody can see how detailed onconephrology is, and that is the reason why it warrants a separate subspecialization. Just to add on what Dr. Wadee said, for the young nephrologists that are on this call, I believe that there are ISN fellowships that are also there for onconephrology. So anybody that is interested, you can visit the ISN website to apply for the onconephrology fellowships as well. So thanks very much, Dr. Wadee, for providing this bird's eye view. I believe this is something that we can all refer to as nephrologists, as physicians, that we are dealing with cancer patients, and we can use it as a reference at least because you have touched more or less on each and everything Some of the things we don't have in our setting, but I think most of the things are available. And I think the practical aspects, especially the last two slides that you shared, the summary and the preventative measures, I think those are very important. If anybody wants to take anything away from this talk, I believe those two slides are the most important ones to try and protect those kidneys from getting complications. Most of the time, the kidneys are innocent bystanders. So yeah, thank you very much again, Dr. Wadee. I believe we have a couple of questions. If you have a bit of time, we can maybe just take these two. So the first the first one is asking about EPO. Can we give EPO to patients with malignancy undergoing chemotherapy who are on hemodialysis?
Thanks, Faisal. So, look, the answer to the question is yes, you can give EPO to patients with malignancy. The question is whether you should in the individual patient. As I mentioned earlier, you would need to individualize. There are guidelines for this question. Certain cancers are more likely to be EPO sensitive or to grow under the influence of EPO, particularly solid organ tumors. Certainly, the hematologists are not too concerned in terms of hematological malignancies for some reason, which is a bit odd to me. But anyway, so I know that in hematological malignancies, they're not too concerned. The guidelines typically say that if the patient is getting palliative care or has an incurable cancer, or the goal is not cure, you can consider EPO dose. You have to individualize it based on the need for transfusion. So if a patient is needing transfusion every week, every 7 or 8 days, you may want to consider EPO to reduce the transfusion need, and knowing well that it may potentially increase the growth of the cancer. But in that context, if the patient's HP doesn't drop, their well-being may be a bit better, and for the little bit of sort of survival that they have, they may have a better quality of life. So it's that type of decision you need to make. In a patient where you're aiming for cure, the suggestion is that you avoid EPO by all means, and you use transfusions where appropriate. But obviously you're going to have to individualize those decisions in consultation with your oncologist.
Thank you, Dr. Wadee. Another question is on the opinion on immune checkpoint inhibitors for treatment of melanoma skin cancer post-kidney transplant.
So I think it's an attractive option to use immune checkpoint inhibitors, but we know that they now induce the sort of immune sort of stimulation. So it's not clear whether they will increase the risk of rejection. It's a really good question, and I think this is something that we're going to have to answer over the next sort of few years. Skin cancer is very common in patients post-transplant. Our current approaches have been to cut them out where possible, to survey them and try and get to them before they cause a problem, to use mTOR inhibitors rather than calcineurin inhibitors to manage the patient's immune suppression while reducing the risk of the cancer growth. But certainly, as patients have metastatic disease and they may require chemotherapy, which may include immune checkpoint inhibitors, we'll have to consider whether they are at risk of rejection of the kidney. And I don't have the answer for that question, Ismail. So that was from Dr. Tikli, and he knows whenever he asks me a question that I'm just going to ask him to provide the answer the next time I see him. So you better read up on it, because I don't know the answer to that one.
Right. Thanks, Dr. Wadee. This was a great presentation, Dr. Wadee. Really thank you for your time. To all the participants and attendees, these videos are recorded and they will be shared on our YouTube channel. So if you would like to revisit this talk, you should be able to visit it in a couple of weeks once it's uploaded onto our YouTube channel. So with that, I would like to thank you, Dr. Wadee, for coming through and giving us your exemplary talk. Prof. Bima has sent his apologies. He had to leave, but we really appreciate your time and the talk, and hopefully we can have another talk with you sometime in the future. Thank you so much.